And it's important to understand that I have financial disclosures, including oculus and brain cornea. And I have to thank my collaborators in Brazil, Portugal, especially the group from Brain, Edileuza Leão, Bernardo Lopes, from the great work. When you think about progressive ectasia, there are two possibilities. You can have an impact from surgery in high myopic patients, like in this first report from 1998 from Seiler. And Seiler himself, he published a few months later another case of ectasia in patients with form fruits keratoconus. So it's different to understand the pathophysiology, that the corneal resistance and the impact from the environment, including laser vision corrective, and the IOLB will be the cause of ectasia because of biomechanical decompensation. A major point is that any cornea may develop ectasia. If you want to avoid ectasia, starts by telling patients not to rub the eye, not to sleep over the eye. That's a major factor that we talk about in our campaign. And it's important to acknowledge the understanding that aggravation of keratoconus is different than causing ectasia, which are different. The first thing that we learn when we start doing refractive surgery is to carefully screen. That's my first publication in 2001 when I start my fellowship with Steve Wilson. We learned that early keratoconus detection is fundamental. And what is early keratoconus? What is mild keratoconus? We evolved now to susceptibility to ectasia development. And also we should think about the impact from the procedure. And these days we were talking about half of the cornea to be preserved, not only leaving 250 of residual stromal bed. It's important to acknowledge the contribution from Brad Lerneman, in which he looked at a scale score with a weighted stratification factor scale, in which age came as a surrogate of biomechanical properties. Age is a surrogate of biomechanics, but it's not specific, because you can have a 21 years old with a strong cornea and a 35 years old with a relatively weak cornea. A very nice series from 300,000 LASIK procedures from Steve Schauborn. He saw cases with stable LASIK and no LASIK ectasia in the form fruits category, which is a category of topometric classification, and cases with a normal tomography that developed ectasia, 30% of cases in his series. So it's important to understand that form fruits keratoconus is a complex definition. There is no consensus. We did a global consensus 5 years ago, and there is no consensus what is form fruits keratoconus. Steve Kleist defined as a fellow eye with very symmetric ectasia with normal topography. This fellow eye would be a form fruits. A mild keratoconus would be a good definition by Jay Krashmer. And if you go back in time, Amsler proposed an incomplete and abortive form of keratoconus that could progress or not. My humble contribution is that form fruits keratoconus is a cornea with high susceptibility for biomechanical decompensation and ectasia progression. And we came to this definition in this report in 2010. The patient had LASIK in the left eye, no surgery in the right eye. If you look in the right eye, she may qualify for LASIK based on topography and 529 central corneal thickness, but the D in the tomography in the Renato Ambròsio display and a low hysteresis in this publication from 2010 would indicate susceptibility. Another case that developed ectasia with relatively normal topography, despite of residual stromal bed of 304 and PTA lower than 0.4, which is a threshold detected by my colleague Marconi Santiago. This patient developed ectasia, and when we see this type of abnormality, we have to think about the subjective classifications. We sent this case along with 24 other cases to 11 experts. The variability is huge. From 0 to 3, the mode was 0. The same cases were sent to the same colleagues with the different classifications in 8 out of the 11 classifiers. And this different scale with a 0.5 normative scale will have a mode of 0 still, but varying now from 0 to 4. So if you look at this case, that will be a good candidate based on a democratic classification by 11 experts. This patient needs something more. And we understand that tomography is different than topography. Front surface curvature mapping, here you have front and back elevation and curvature and also thickness mapping. We want to make things more simple, not simpler. And that's a very important consideration when we started to work with the Renato Ambròsio display. And here you can see the threshold for susceptibility that this patient had low artmax, high D. This would indicate susceptibility. The patient has 20/20 plus or 20/15 distance correct vision with a green topography and should not be considered a keratoconus, but is a susceptible or a diffuse keratoconus. We'll come back to this case in just a little bit. A very nice report from Elnagar on the LASIK ectasia, on a smile causing ectasia. He sent me the pre-op tomography data, and we could calculate many of these indices, and you can see that despite of the low K, this is something that we call as low K keratoconus. Low K keratoconus is when the K max is lower than 46, and 8 to 10% of clinical keratoconus have a keratometric maximal curvature map in the axial curvature maps lower than 46. In this case, has 44.6 and 43.9. So the conundrum of ectasia comes now to over 20 years. We have to understand that this is acknowledged by many of the reports in the 30,000 LASIK procedures by Dr. Bohak. We found 10 cases of ectasia, and these cases were hard to be detected, the risk factors. 3 out of 10 had the residual stromal value lower than 300, and only 2 out of 10 a PTA higher than 40%. In our series, we had 3,278 normal stable cases of 2 years follow-up plus, and 105 ectasia cases. And you can see here the dot plots of age, PTA, and residual stromal bad. Interestingly, if you go to the IS value, absolute, which means that if you have superior steepening, you would have also a positive value. You see that's very specific, but that's not sensitive. It means that people are obeying the rule of not doing LASIK in patients with asymmetric corneal curvature maps, which is something that is not going to be sensitive because only 22.9% of these cases would have abnormal IS values. The bad D goes to 59%. It can change if you change the cutoff value, but you need something else. And that's part of the great work from Bernardo Lopes in his thesis, in which you can include the disease population, the normal topography eye from patients that had keratoconus in the fellow eye. And this Tetacam random forest index, which is artificial intelligence based, you increase the sensitivity to 74% and the specificity to 94%. However, you have to include the integrated data with the impact from surgery, and that's the relational tissue altered concept that we presented at the ASCRS. And along with the PRFI and other parameters, including age, you can improve the sensitivity. But you still have cases down here. These cases down here lead us to the knowledge of the need for biological properties. And we have one healing from Steve Wilson's lab work and many other contributors, and biomechanical properties. And biomechanical properties were, we started studying it in 2006 with the ocular response analyzer. Looking for 41 years old, you see the curvature map from Placido and the shine fluid. That's the case published in 2010. Everything will be normal, but you have a little yellow here. When you integrate the data with a tomographic and biomechanical display with the Corvus, in which you have much more data to be analyzed based on the dynamic shine fluid response, you have a TBI of 0.78. Very interestingly, the son of this patient with 11 years old, 20/20 distance corrected, relatively normal, innocent topography in the right eye. You have a little bit of inferior stiffening here though, but here you have a possible. And this is something that we call as very mild or diffuse keratoconus in both eyes. We see from the first publication, the JRS in 2017, patients that if you optimize the normal topography, patients are going to be detected with a better cutoff value, but this will be an epitome of the ectasia susceptibility. We are aware that cases with lower sensitivity were published in the literature, and it gives us the opportunity to improve, to optimize the artificial intelligence of the TBI, including 25 international centers, one randomly selected from a large cohort of clinical norms, 1,679 cases, large cohorts of keratoconus cases, and 543 cases with normal topography in which the fellow eye had clinical keratoconus. And these are the unoperated eyes that had exam. So it's interesting to see that the bad D has a very good sensitivity to detect ectasia in the clinical keratoconus in VAE and the KC, but not the normal topography eyes. So we did artificial intelligence with different methods, different approaches, different algorithms, and the random forest was the best one. And here I present you what we presented at the ASRS as well. The random forest optimized that you can improve even the clinical keratoconus. You have 99% versus 98.4% here, with the specificity also increasing, but you have cases leaking here with normal topography, normal clinical data that are normal. But here you see the advantage increasing from 75% to 85% on the normal topography eye. It's interesting to see these two situations in those normal topography eyes. This patient has 2015 dyscorrect vision, and the fellow eye would say that she has clinical keratoconus, a mild keratoconus. Considering the TBI, she would be abnormal. So this is a very high susceptibility for ectasia, and this exam confirms formed fruit keratoconus in this VAENT case. However, we have to understand the systematic review from subclinical keratoconus and formed fruits. There is huge variability on the literature, what is formed fruits and what is subclinical. So we have a consensus that true unilateral keratoconus does not exist. And also we have a consensus that secondary ectasia can occur due to a pure mechanical process, and that can be unilateral. So this is the case of unilateral ectasia. This patient comes with a very asymmetric disease. The fellow eye, the left eye, has 20/20 plus uncorrected vision. This patient had a great result with a corneal ring. He moved to London, and then Reinstein did his great examination, his extended examination, including epithelial thickness. He still does the orb scan with the Mianga-Tinel and the Lansat. We got the data to calculate the score, which was normal. And this patient comes back to me a few years later, and he's very stable in the left eye. He's still doing well in the right eye, but I can show you that the TBI 002 looks like, confirms the unilateral ectasia that we published a few years ago. It goes to segmental layer. So it's important to understand that we are evolving and going beyond, not over tomography and biomechanics, into the tomography domain for epithelial thickness. This layer, micro-layer tomography, you can see the epithelium, you can see the Bowman's layer, you can see the endothelium for Fuchs dystrophy and rejection, other things. So we are really expanding revolution in the imaging for cornea data. And this is something you can see for understanding. For example, this patient that had the ring, you see the ultrasound and the high frequency ultrasound, the OCT, you can see the hyperplasia, which is a secondary effect from the because the elevated, more elevated area. We cannot talk about epithelial thickness without mentioning the great work from Dan Reinstein with the high frequency ultrasound. But today, because of the great work from David Duquan, who invented the OCT, and his collaborator Yan Li, we had epithelial thickness from OCT that has been available from many companies. So screening for ectasia, it goes to artificial intelligence based on multimodal imaging. And artificial intelligence also is important to understand the impact from surgery. It's very important to understand the concept of tissue alter that is in relational to the cornea. So in relation to the thinnest point, in relation to the patient's age, we can calculate how the cornea can be impacted, and considering how the cornea is strong or not in the case of susceptibility pre-op, we can improve patient's care. So I'd like to invite you all to the Violet June campaign. 2020 will be a very important year for ophthalmology, and maybe I was having high expectation for the Violet June, the keratoconus awareness campaign we started here in Rio. It's not my campaign, it's a campaign from Brazilian ophthalmology, and it's a global campaign, global ophthalmology campaign to bring keratoconus awareness. The main message is to tell people not to rub the eye, but it goes much beyond that, explaining patients about keratoconus, which is truly a new subspecialty. However, violet is a very important color because it means healing, rejuvenation, and that's all we want to have in this difficult time. And June is the month we're coming back to normal. Actually, the new normal is coming. So I invite all of you to consider posting on Violet June in the next weeks. Thank you very much for your attention.